We're very lucky today to have Dr. Kevin Croce from Brigham and Women's Hospital. He's the director of CTO and complex coronary artery intervention. He's also the director of the Brigham and Women's Translational Discovery Lab. Many of you know him, have heard him speak. He's an international expert in intravascular imaging and complex PCI. And without further ado, Dr. Croce, thank you for being with us today. I think you're muted, Kevin.
Yeah, thanks everyone. I commend the BMC2 team. The fact that this is being tracked in such a high fidelity way in this initiative, I think is really progressive. So I think it's a little bit of probably preaching to the choir here, because I think there's been more uptake in Michigan than there has been nationally. So credit to you and your colleagues, I think, for having interest in this important topic. With that in mind, I'll try to get through a little bit of the background slides quickly, because I think, you know, the evidence to support image-guided PCI is robust. And we can talk a little about our experience. This is meant to be sort of a journey of our lab. Our cath lab sort of read the data and saw things, recognized our desire to increase our imaging utilization, and then move forward to implement it. If you wouldn't mind, may I share my deck with the team?
Please do.
Thank you. My slides coming through okay? Great. So in full disclosure of my financial interests, I do consult for all of the major imaging companies around research and development projects, and also around training and education to increase the uptake of IVUS OCT, and to help build computer systems that make it easier to use these tools, which has been a fun part of my work in this space from a development perspective. So if we were going to think about why we want to use imaging to support PCI, I mean, we'd like to improve outcomes, make PCI more precise, faster, easier, and hopefully show an economic benefit. And we can talk about each of these individually. You know, the barriers to utilization of imaging is multiple. You know, we've been doing PCI for a long time using the angiogram, and some still believe that's good enough because we've been doing that way for a long time. You know, when I was a fellow, there was no proof that intravascular imaging changed outcomes at all. That's changed. And we really will focus a little bit on lack of training, how long it takes, and the cost of the procedure, which I think are important conversations as we embark on potentially increasing utilization at various hospitals, or as a state, or as a healthcare system. So looking at the concept that the angiogram is good enough, this slide is just meant to really show that if we look at an angiogram, there's a lot of variability in how they're read. And so consistency of making decisions based on observer assessment of lesion diameter stenosis is highly variable. And I just sort of have this there to make the point that, you know, if we put our thumb up in the cath lab and say it's a 75% lesion, we should fix it, that's probably fraught with a lot of error potentially, because the angiogram percent stenosis is a little bit in the eye of the beholder, and making decisions that way for patients is an inexact tool, as shown by this slide. We also know that physiology-guided PCI, through data we won't go through, but I think everyone's aware of, has dramatic benefit in terms of, you know, FAME1, FAME2, and many registries which show the benefit of physiology-guided PCI. If you look at the way that percent diameter stenosis corresponds to FFR, you see that in the 50 to 70% range, we typically defer intervention. A lot of these patients actually have abnormal FFR values. And in the 71 to 90% range, we typically treat patients, 20% of them actually have normal FFR. So it just really highlights the difference between percent diameter stenosis by angiography compared to what values we get if you use physiology. And I think many labs have moved to using physiology for intermediate lesion assessment, determination of whether to fix. When the angiogram gets to about 90% stenosis, it starts to track a little bit more closely with FFR values. So, you know, percent diameter stenosis as a way to make decisions of whether to revascularize patients doesn't correlate well with FFR, and FFR is pretty well validated to be a good way to decide whether to treat a specific lesion for patients. So we sort of looked, you know, thinking about the way that the angiogram works to guide interventions. We were asked of one of many centers to take part in a study called Light Lab. I'll come back to you a couple times throughout this talk, but this is just asking if you use image guidance. In this particular case, we were using OCT to guide your case. How does it help you to change your decision-making based on what you do with the angiogram alone? And we were approached to do this study, said, you know, I've been using OCT and IVUS for a long time. I think I've retrained my eye. I'm probably better at sizing than I used to be, but this will be a cool experiment. We'll take part in the study and sort of see how we do. And then, you know, this is my personal data, which came out as the first bit of Light Lab on this slide. What I found is, you know, my thought that I was better at sizing stents for length and diameter, diameter on the left and length on the bottom here, was actually wrong. I was joking with my colleagues, maybe I need to go back to fellowship, because if I actually used OCT to assess the size and length of the stent, it changed what I would do about 76% of the time. And so I think, for me, this was sobering, because I thought I've been imaging for a while. I've gotten my IVUS or my OCT eyes better than using the angiogram. But if you actually use the tool, I was surprised how often I make different decisions based on the intravascular imaging alone. I felt a little bit better that if you look at the entire light lab cohort, we see that about 40% of the time, physicians that use OCT in light lab to actually change, to decide on what size stent, either oversized or undersized. And so I'm not just the only one in our group who's getting it a little bit wrong or making different decisions if you use the intravascular imaging. This is a study that our friend Alan Jeremias published, and it just shows a little bit the potential hazard of angio-guided PCI. This is defined PCI. It's really simple. The case was done based on using the angiogram to decide what to treat and how to treat it. And at the end of the case, a blinded IFR pullback was done just to see what the residual value was. And I think surprisingly, 24% of patients were left with an abnormal IFR value. And of that 24%, about 80% of those patients had focal disease. My CHIP fellow Moda made this slide for me. And the thing we were struck by is that of the patients who had abnormal IFR values at the end of their PCI, when there was no more than a 50% stenosis left on the angiogram, about 38% of the major pressure drop was in the stent that was just placed. This obviously wasn't an image-guided study. And I think it shows a little bit the possibility if there is an opportunity to do a better job in terms of ischemia reduction if we use different tools other than just using the angiogram. And this is now the foundation of an ongoing clinical trial called Define GPS, which is using resting physiology pullbacks to try to treat patients to a normalized resting physiology value if possible. And that's an ongoing study that Brian Bergmark, my partner, is our local PI for. And it's pretty cool. It has the potential, if it works, to change how we practice for patients. But more on that to come over the next couple of years. So if you think about the fact that, over time, we've evolved to the place where there really is proof that intravascular imaging impacts outcomes. These are the two randomized trials, which are IVUS-guided studies, IVUS XPL and Ultimate. They were done on two different continents a couple of years apart. And amazingly, we see the angio-guided PCI is inferior to IVUS-guided PCI with a MACE endpoint that was largely driven by a stent failure. And numerically, you get almost the exact same result in these two studies. IVUS XPL was a complex patient subset, which was defined as stent length greater than 28 millimeters. I know a lot of the operators on this call, if you're just making your case complex because it was 28 millimeters, it's actually a really easy day. And so the bar to meet complexity in the study was quite low. And then Ultimate was an all-comer study. And so thinking about this, I'm getting some sense from the two main randomized trials in this space that intravascular imaging cut stent failure in half. If you then look to say, all right, the other data in this space is, a very nice meta-analysis. Again, we don't have any single trial which is powered for an endpoint we really care about, which is cardiovascular mortality. But, all arrows start to point toward a benefit to intravascular imaging. In this particular meta-analysis, which includes IVUS XPL and Ultimate, there seems to be a dramatic reduction in cardiovascular mortality for image-guided PCI. Many of the large registries track the same way. IVUS and OCT are better than angiography in large registries in terms of reducing the incidence of death in patients that get image-guided versus angio-guided PCI. And this is a slide I borrowed from Gary Mintz, which sort of shows the totality of data. It's not meant to be read. Oh, sorry about that. It's not meant to be read. It just sort of talks about the large volume of data which supports image-guided PCI, randomized trials, meta-analyses, and registries. The place where we see a dramatic benefit also is in left main guided PCI, where any number of meta-analyses and studies have demonstrated a benefit. And I think many believe that in this current era, left main guided PCI is obligate to do intravascular imaging because of the importance of what we're doing in those particular cases. So if you think now about, how we use intravascular imaging, this is a paper which we and colleagues recently published about a month and a half ago. And all it does is ask a simple question. If you were to guide a case based on an angiogram and then did a pre-PCI imaging run, in this case, we're using OCT, we just look to see how it would change decision-making throughout the case. And the cadence of the case is looking at lesion type, how you're going to treat, how you're going to prep, stent length, stent diameter. On the back end, the post-PCI, how you're going to optimize the stent. And we see through the different phases of intervention, if you use the intravascular imaging to plan the intervention, and then use it with a second run to optimize the stent, we see a change in lesion assessment and execution of various steps in the case that matter for things like choosing stent diameter and addressing underexpansion. And over the cadence of doing the intervention from planning to executing optimization, the imaging changes what we do 88% of the time. And the cool part about this is we start to get some highlights to the difference between an image-guided PCI versus an image-endorsed PCI. I have to be honest, for the first 5 years I was in practice, if I used imaging, which wasn't very frequently, I would check my stent on the back end. That's very different than doing a prescriptive assessment of the lesion beforehand, the length and the diameter, and then choosing to plan your case based on the imaging. If you do that, you actually have a lot less work on the back end. And that's how we start to see some of the efficiencies of image-guided PCI. If you actually do intravascular imaging to plan the case, it moves pretty quickly because you know exactly what you're doing for the next steps that follow based on accurate data, which is gleaned from the intravascular imaging run. If you use a similar cadence of how intravascular imaging changes decision-making in in-stent restenosis, I think it was nice to see that ISR is one of the initiatives that BMC is including, where ISR and stent thrombosis are places where imaging could have a dramatic impact in changing what we do. We see in similar analysis, if you look at the impact of intravascular imaging on ISR treatment, it changes assessment and execution 95% of the time. And so, you know, there's a more dramatic impact of imaging and treating ISR even than in de novo lesions. And so we think about, you know, what is the main predictor of stent failure? There's multiple things. I think the highest hazard of stent failure is small stents and potentially underexpanded stents. The other things we care about are landing in distal disease or landing in proximal disease. Everything in red is a hazard of MACE for stents that failed. So, and the other thing which is important is that we don't leave distal edge dissections, which tend to be more noxious than proximal edge dissections. You know, when I was a fellow, we cared a lot about malapposition because we thought that was leading to a hazard of stent thrombosis back in the Cypher and Taxus era. But if you actually look at this, malapose stents that are well expanded, understanding the difference between apposition versus expansion, typically don't have a high hazard of MACE. You know, we don't want to purposely leave stents malapose, but the things that seem to really matter for outcomes are big stents, landing in normal reference segments when possible, and not leaving distal edge dissections. Proximal edge dissections are probably a little less dangerous because they can't track distal because the stent protects them from tracking distal and raising a hematome and obstructing flow. And so if you think about, you know, how intravascular imaging changes the outcomes of patients, this is a meta-analysis which just demonstrated a marked increase in stent size if you use intravascular imaging to guide the PCI. So if we know that small stents have a higher hazard of MACE, and intravascular imaging makes stents bigger, it's not too hard to deduce what the probable mechanism of benefit of image-guided PCI is for patients that have their stents placed with image guidance. So based on the imaging data, you know, you could ponder the question, should everyone get an image-guided PCI? In the United States, based on which data you look at, it varies somewhere between 14 to 18 to 24% of patients in the US get image-guided PCI. This varies differently from Japan, where it's about 95%. And at least from, you know, what is the right number standpoint, I'm always intrigued by the fact that there's such practice variation with two developed countries that are doing the same procedure. And I think that'll be fodder for conversation as we get into the discussional phase of this evening. And so the other cool part is, you know, this is data from the National Inpatient Database. It's plotted differently than what Devrod showed. But effectively, I put this slide in the deck because much like you're seeing in Michigan, if you say that 20% of all US PCIs are image guided, that's not to say every hospital is doing 20%. Many are doing very little, and the mean and median are being driven up by several outliers. And so we see that there's a high utilization in a small number of centers and very little utilization in a lot of centers. This is older data, but I think it's sort of, I was struck by the fact that this is not a bell-shaped curve. It really is skewed to the left side. And I think it's a conversation for what the right number would be if you're moving forward to try to get this input as a quality perspective. And obviously, Michigan has set a number down, which you guys reviewed in the first couple slides, which I found incredibly interesting. The other thing we've been struck by is the lack of training. I mean, any training I've had in image-guided PCI, either IVS or OCT, came after my fellowship because we really didn't have prescriptive strategies for how to use these tools. And this is something that I've taken a personal interest in and worked a lot to try to come up with pathways and accessibility of training for using these tools in a way which is based in the data and using them in a way which actually helps us to do a good job quickly so that it doesn't need to take forever. I mean, I'm sort of, you know, mindful of expediency to a fault. We want this to be simple, straightforward, easy to use so we can help increase uptake. This is data from the CRF Fellows course. It was published a couple of years ago. I borrowed this slide from my colleague Ziad Ali, and we were struck by the fact that if you ask fellows that are graduating about their self-reported proficiency in things like physiology, IVUS, and OCT, we were struck by the fact that at least half of our fellows didn't feel comfortable doing an IVUS or an OCT guided PCI. And that's an opportunity for improvement because we as their mentors need to be teaching these things. And so with that in mind, a couple of years ago now, colleagues listed on the slide and I got together in Boston, really with the idea that we recognize all of us were doing IVUS and OCT guided PCI differently. We were teaching it differently, using different nomenclature. And in large part, this is probably leading to some confusion in the field. So what our goal was to get everyone together so we could agree upon a prescriptive strategy of the best way to come up with a way to teach this in a way which was simple, straightforward, and generally agreed upon. This wasn't meant to be, a Bible or an edict on this is the only way to do image-guided PCI, but it was meant to bring a little bit of consistency among those of us that were trying to teach this and sort of increase adoption. And so with this in mind, after 2 days, we came up with this acronym called MLD Max, which I'm sure many of you have heard of already. And this is not just for OCT. We really advocate doing IVUS and OCT guided PCIs using this strategy, although it was originally developed for OCT because that was one of the places where we were doing a lot of clinical development and research at the time. And then the whole amount of this is that you really need to do a pre-PCI imaging run to strategize what you're going to do in the case. I showed you the aggregate benefit of that in the light lab data that I presented a couple slides ago. And it's just really simple. There's an algorithm for how to do image-guided PCI. You look at the morphology to determine how much calcium there is and where you're going to land your stent. You choose the length of the stent, hopefully being able to land in normal segments, or at least most normal segments, and then use the imaging information to choose the diameter of stent based on the distal reference segment. And the nice part about this is from an expediency standpoint, once you've determined what the morphology, length, and diameter are, if it's not an atherectomy case, I will ask my technical staff to drop that length stent and the 2 post-dilation balloons I'm going to use to optimize the stent. So at this point, you're making decisions and moving relatively quickly because you know exactly what type of treatment the artery calls for. Once a stent is implanted, we do a post-PCI imaging run to look for the presence or absence of medial dissections. We look at apposition to the extent that grossly malopose stents are going to be a hazard to you or your partners if you have to come back and treat the patient in the future. And then the holy grail of outcomes is really focused on getting good expansion because we know that's the greatest predictor of stents staying open over the long term. We recently published the sort of cookbook of how to do this in CCI. Here's the reference for it. We won't have time tonight to go through in detail how to do an MLD max guided PCI, although I'm happy to answer questions about it and have some kernels of the things I think that matter from the algorithm that we'll go over in a couple slides. But there's a lot of training tools, and there's really well-vetted ways to learn how to do this quickly for both IVUS and for OCT that I'd be happy to chat with the team about as we end the session tonight. The other cool part about this is an example from OCT, but there's many IVUS algorithms which are in development and are near release. But to make it easier for us to use these tools as physicians, computers are going to help us in the future, where the computers are able to recognize calcium and tell us the arc of calcium. And they're also able to recognize EEL, which is what we use for vessel sizing for balloons and stents for OCT. There's very similar computer algorithms which are being made for IVUS by all the major manufacturers, which just aren't yet commercially available, so I'm not able to share them. But I think this is going to be a little bit easier because it's going to take the onus of interpretation off of us, which is cool. So for new users, you get a little bit of coaching while you're working with these tools, which I think will be some benefit to you. And as we designed MLD Max, we really tried to focus on things that were simple and meaningful. You can see macrophages by OCT. It doesn't matter for clinical decision making. We really care about calcium, sizing, and landing zones, and making sure the stent's big and making sure there's no dissection. So we've tried to boil this down into something which is both teachable and can be readily learned and applied in real cases. And so if you think about that, the other thing we really care about for stent expansion is morphology. I won't go into this in too much detail, except to say that there's really well-vetted calcium scoring systems, which are simple for both OCT and for IVUS. This is the OCT one. If the calcium arc is greater than is about 360 degrees, or is 0.5 millimeter thick, or is 5 millimeters long, you can see as you add up points, your stent expansion starts to fall below 80%, which is the goal of an image optimized PCI. There's a very similar scoring system for IVUS that looks at the calcium arc and the length, that looks to see if it's greater than 360 degrees, that looks for the presence of nodules, and then looks at vessel diameters, with smaller diameter vessels getting a point because those tend to be harder to expand. If you have 2, 3, or 4 points, you should consider atherectomy, because this data shows in the validation set that if you don't do advanced vessel prep, your stent is less likely to expand to an optimal way. And so the cool part about this is, from a training standpoint, we used to see calcium by IVUS, but we really didn't have an informed way to discuss what's actionable calcium. That's changed. We now have an idea of how calcium signatures by IVUS correspond to stent expansion, something we really care about if we're doing an image-guided PCI. So that in mind, what defines an MLD max optimized PCI? It's really getting rid of the things highlighted bottom left that we know drive MACE and drive stent failure. So M stands for making sure there's no medial dissections. We care about dissections if they're greater than 90 degrees, if they involve the media, and especially if they're at the distal edge. We care about apposition to the extent that we don't want to leave grossly malapose stents greater than 3 millimeters long or greater than 0.3 millimeters from the wall. These are a hazard, especially if they're proximal, if you have to retreat the patient in the future. And we really focus on expansion. And in this particular case, we talk about minimal stent area as a percentage of expansion of the reference area. And we could talk about how to do this, but it's really easy. If you're used to using IVUS and you use the little dots where you draw circles, you pretty much draw a circle at the edge of the stent, proximal, and at the edge of the stent distal. And you get that area. And you just add up that area, divide by 2, and take an average. And then you find the smallest spot of your stent in the stented segment and determine that MSA. And that becomes a percentage of the reference area. So it's really easy to do this, even with IVUS systems that don't have the automation that OCT has. And so this is a relatively straightforward and simple thing to learn. There's lots of teaching tools. We've got some decks just on how to follow the bouncing ball or paint by numbers with regard to how to execute an image-guided or image-optimized PCI. And so with that in mind, thinking about MLD max for left main, I think, many people would agree that there's a value to image-guided PCI in left main stenting, but it's not enough just to drop the IVUS and look around. There are validated data in terms of area, in terms of the left circ, the LAD, the point of confluence, which is the area where the 2 branches come off, and the left main shaft. These numbers of area of 5, 6, 7, 8 or where you start to get freedom from MACE and left main PCI. These are often called the Kang criteria. They were validated in an Asian population. So I think when we talk about utilization of this in the US, we like to see the numbers be about 1 millimeter bigger, especially in large frame people like myself. I'm 6'2" and weigh 210 pounds. And so I think, if I'm getting a left main stent, I'd hope to see 6, 7, 8, 9, but 5, 6, 7, 8 is where the derivation set for the initial Asian population came from. And so think about, we've made a push for the fact that there's value to image guided PCI, but what's the cost in terms of how long does it take? I'm busy. We all have our kids and our family and soccer practices. This is something we wanted to think about and answer to the best that we could in Light Lab. And so if you look at the Light Lab, which is a use of MLD max in OCT guided PCI in 12 centers with 40 operators, a third of who were brand new OCT users. This is real world, with 55% of the cases being type C lesions, a large number being also ISR and long lesions. You just ask the question, how long does it take to do this after 20 training sessions, 20 training cases? And what we see is this is compared to an angio-guided PCI. So angio in blue, the OCT here on the right. Because it's OCT, there's 6 minutes for the pre-PCI OCT, which isn't in the angio-guided arm. And then you have the post-PCI optimization. It only takes 9 extra minutes to do an MLD max guided OCT assisted PCI. And so that was really helpful to say, all right, once we get a workflow that is, helpful, validated, and a little bit of training, people can do this in a relatively expeditious way. If you look at the data from Disrupt C83, which was a shockwave trial, which actually had an OCT arm to it, you can see that the OCT guidance in calcified lesions in the shockwave trial didn't take any longer than the angio guided. And so it's kind of a validation of what we saw in Light Lab, where it took 9 extra minutes in Light Lab. In another clinical trial, it took no time at all, probably because the physicians were somewhat practiced at it and they were making decisions about calcium and decisions about stent placement that we hope is speeding other parts of the case that makes up for the fact that you're doing the imaging run. when we think about procedure costs, if we look at light lab, if you guide the case based on the OCT compared to the angio cases, you actually use less stents, probably because you're having less edge dissections, you're landing in the appropriate place, and you're having less complications, the initial stent, you have less optimization to do. And similarly, if you think about cost to our healthcare system, these are data from any number of our modern DES trials. And we see that, 1 in 8 patients are back within 5 years with in-stent restenosis. This is a terrible cost to our healthcare system. And if you look currently in NCDR, about 12.5% of US PCIs are currently to treat in-stent restenosis. If we do about 1 million PCIs per year, this is about 80,000 cases per year. And we know that imaging cuts target lesion failure in half. And so if we use intravascular imaging in a more judicious way, we potentially are going to reduce the number of patients that are coming back for repeat treatment for stents that have failed, because we know that image-guided PCI and the randomized trials, the main thing it does from the primary endpoint is it cuts down stent failure. So this is a nice paper which Sunil wrote a couple of years ago. It just talks about performance metrics to improve quality in contemporary PCI. And this is an opinion piece, but I put this in there because I'm excited to share a conversation with the group in Michigan, because you guys are thinking a lot like Sunil is, comprehensive use of physiology to identify ischemia-associated lesions and imaging to optimize stenting are contemporary features of high-quality PCI. And this really is a call to what our expectations should be. And so, when IVUS XPL was presented at TCT, Brian Bergmark, my partner, and I, that are our main complex PC operators, were sort of out on the end of the curve using a lot more imaging than our partners were. And this is our cath lab director, Binny Shah, who's a dear friend. He came back to us after TCT and said, hey, Kevin and Brian, all right, we really need to amp up our ability to program to use intravascular imaging, because I believe now that data is in a place where it warrants consideration for doing more as a team than we are currently. And so we asked Brian to make these posters, which sit on every wall in our cath lab. You can see that there's a light switch, so they're pretty big. And they're just sort of the Brigham and Women's Hospital way to do either an OCT or an IVUS guided PCI. These largely follow the MLD Max protocol. If I was going to redesign these today, I'd just make them MLD Max because we've been teaching to it a little bit more simply that way. But the cool part about this is when Binny put this on Twitter, he got about 20 requests to send the PDF to people, because I think there was a yearning for consistency of how to do this. And with this in mind, then, it wasn't just a matter of putting some posters up and saying we need to do this. We really went as a team and tried to do things that we knew would help adoption. Those things included training our staff, training our partners that weren't regular image utilizers, and really giving support to everybody and having this be part of the conversation of what are we learning from this? Are we getting better, faster? What are our struggles? And Brian actually published this really cool paper, which just talks about how to integrate imaging into PCI workflow and cath lab culture. Brian and I went at 7:30 for 3 weeks in a row and gave a very similar talk to our technical staff. We then had a training deck for OCT and a training deck for IVUS on how to do an image-guided PCI. We really just took them through the menus, showed them how to use the computer, and really showed them how MLD Max is applied either to OCT or to IVUS. So everybody had a little bit of an idea as we started this on how to execute the assessment of how to plan the case and how to make sure the stent is well optimized. And we'd be happy to share these resources with the team if it's helpful. And then to Binny's credit, he's like, all right, well, if we care about this, we're going to track it as a quality initiative. So if you look here, this is in 2019, right about the time that we decided we were going to roll this out, and we were imaging about 20 to 30% as a program. As a program, this number was driven up from a lower number by the 2 people that use imaging a lot. And now every month in our quality conference, our M&M, we track image-guided PCI as a percentage, and we sort of hover in the 80 to 85% typically. Last month, I was excited to see it was 91%. This is data from a couple of years ago. It just shows an example of how we're tracking this now. But it's not just to use the imaging. I think being able to have a conversation of I'm using it in a prescriptive way, where I know the goal of an image-guided PCI is to make sure my stent is expanded well and I don't leave major dissections, is a large part of the conversation. And my buddy Asim Latib in New York said, hey, we started doing the same thing, Kevin, but I recognize people were using it. They need to use it in a way which is really deliberate, recognizes what we're trying to do with an endpoint of the image-guided PCI being done in a way which is associated with better outcomes. Using it is good, but using it for optimization execution is really the name of the game here. The other cool thing that happens is I get all sorts of my personal data quarterly. This is our 7 operators in our cath lab. I show you by example PCI radial percentage by operator. In particular, I'm usually dragging this down because I still at times need to use femoral access for some of the complex CTOs that I do. But we also see PCI imaging percentage by operator. This is de-identified to be non-threatening. This is older data early in our experience, but you can see there's a lot of variability. And if I showed you the data from last quarter, most people are over, I think everybody's over 70%. And so we've sort of seen even evolution by being able to see what we're doing as individual operators compared to our partners. And this is for all things like case cost, contrast utilization. It's helpful. It's not meant to be threatening. I think it just shows from a quality perspective, things that we think are important to better outcomes, we get a sense of seeing where we stand relative to our peers, which helps us understand if there's something we might want to consider to do to evolve our practice along things like access, contrast, time, even things like first case time on start are there by operators. So we can see if we're not getting patients through the system, we can think of work about efficiency. And so it's a way to kind of have a conversation about quality in my mind in a non-threatening manner. So final thoughts here, if we use modern PCI tools such as physiology and imaging that we know are better in the angiogram, if we weren't under-treating and over-treating patients by the angiogram compared to, say, what you would do if you used FFR, if we weren't leaving a quarter of our patients ischemic at the end of the case, as was shown by Alan's study to define PCI, if we were cutting down stent failure by 50%, and if we were getting outcomes that looked like Syntax 2, which was a single arm study, but they used physiology, modern stents, modern tools, and showed that PCI looks better in the current era using these tools than older era with Syntax 1, you just wonder if we might be able to finally show hard endpoints in elective PCI, or at least do better compared to CABG, where the one thing we always lose to with surgical intervention is obviously target vessel revascularization because of stent failure. So with that in mind, the evidence for routine vascular imaging, the angiogram is a blunt tool. We know it's a poor predictor of ischemia. It's not a great predictor of PCI success, and that's the entire foundation of this new study, Define GPS, that we talked about. Image-guided PCI reduces stent failure by 50%, and it saves lives, at least in meta-analyses. And I believe that intravascular imaging is underutilized PCI, and I really commend the Michigan team for having a conversation about this as a healthcare system, as a state. And I'm happy to answer any questions or talk through our experience in terms of how we move forward to adopt this at our center. And thank you very much for the invitation. I was excited to be part of this today.
Thank you so much, Kevin. Great talk. We're going to throw out the slides real quick. We just have a couple more slides that tag along to the end of your talk nicely, and then we'll open it up for questions. We appreciate all the great content about the benefit of intravascular imaging, but then also sharing your experience within the Brigham and Women's Cath Lab. I think many of us are trying to think about not only how to increase our own utilization of intravascular imaging and interpretation, but also how to educate our fellows, our colleagues, our tech team, and our nurses. Post on the BMC2 website is a kind of a quick handout of some resources that we've compiled. The first one being a lot of the data that we showed earlier in the presentation, and the second one being linked with QR codes, some useful documents and publications with various algorithms, as well as those YouTube videos are the great Berlakis videos on YouTube, which I'll often go to for good content. We also put together, if I again can figure out how to control this, put together some posters. I'll admit this was spurred by going out to Brigham and seeing the posters on your wall and asking your colleague Brian, who's been immensely helpful in helping us sort this out. I thought it was a fantastic idea in terms of dissemination of education and trying to boil down how to do imaging guided PCI. So we have a version of a poster here. This was put together by one of our fellows, Ashwini Kirkar, and the BMC2 best practice group of Dr. Mader and Baye and Daher and Tuchiaron and Hitinder and myself, in trying to boil down kind of the pre-PCI imaging bullet points and the post-PCI imaging bullet points, many of which are mentioned in MLD Max. And we actually have a version that goes step by step through MLD Max as well, and incorporated some calcium modification considerations using imaging. And then, as recommended by Dr. Valle, maybe a potential second version of just boiling it down to pre and post imaging and a calcium modification group. So we'll touch these up a little bit and put together a handful of various poster sizes that can be downloaded for everyone's cath labs if you find it helpful, and can post on your walls to use for education and to expedite intravascular imaging.